practitioner from the Hospital for Sick Children, and I'm going to start the evening off with the presentation from the pediatric perspective about what is routine follow-up in tuberous sclerosis in children. So I come from the Hospital for Sick Children. This is a sort of a view from somebody staring in our atrium up to the ceiling. It's kind of a unique picture. So I'll give you a little bit of history about our clinic at the Hospital for Sick Children. It started with Dr. McCoy and myself, and our first clinic was held in January of 2016, and it was created because there was parental demand for a TSC clinic. We had a lot of TSC patients, but people were talking about mTOR inhibitors and things like that. That care was not happening. So we thought, well, we can change care. So let's try and we were asked to do a TSC clinic, and of course we did that. So we used to have one full day a month, and it was usually a Friday. Now we're doing a half day a week, so it's usually a Friday morning, kind of going a little bit into the afternoon. Initially it was Dr. McCoy and myself, and we had a nurse, Valerie Chan, and then we had 0.15 of an admin coordinator, obviously residents and fellows, and paper requisitions because we didn't have Epic, our computer system, our electronic health system. Now we have our director, Dr. Erin Sham. She's back from maternity leave. Dr. Elizabeth Donner, she is our division head. She was covering for a year. Samira in the left-hand corner, she looks lovely there. She is our TSC program navigator, and she joined us a few years ago, so we're so lucky to have her. And I couldn't find pictures of the rest of our team, but our nurse, Amel Warsami, is our clinic nurse. Mila Vlacic is our research coordinator. We're lucky now because of a fund that we have, Parents Raise Money. We have Ritaj Abumar, who's a research summer student. She's a medical student. We have about 150 patients in our clinic, and the tuberous sclerosis clinic is the medical home. That's me when I was looking better in my youth. Okay. And then the other main characters are Dr. Mathieu Lemaire and Dr. Christoph Licht. They're the nephrologists. So in the early days, we had multidisciplinary clinics. Everybody wanted multidisciplinary, so we thought, well, we're going to deliver. So we tried it, and we had neurology coming, dermatology, but people ended up waiting for them to come because they were running their own clinics, and it was an excessive wait. It was inefficient. Families often got information, so if they were getting information on certain test results or having to deal with epilepsy and then getting other results, they were often overwhelmed. Children with developmental disabilities and autism, they decompensated ages ago. It was a full-day clinic. Was it a good idea? We thought initially, but not so much. This is a graphic from, I don't know if anybody remembers the Marx Brothers. And they did this little skit where everybody was kind of going into one room, and they tried to pile as many people into the room, and finally they had too many people, and the next person that opened the door, everybody fell out. That was kind of like what happened for us. So our tuberous sclerosis clinic, just a quick reminder of tuberous sclerosis. It's a rare genetic disorder, and it can affect any organ system. Lifelong surveillance and management are crucial, and the clinical manifestations are varied in the age of onset and with the extent of systemic involvement and severity. And the clinical features they present dynamically over the course of an individual's life. Here in this graphic, we have a little picture of a lot of the manifestations of tuberous sclerosis. Of course, not everyone gets everything, but you could see the proportion of people. Hopefully it's not too small: intellectual disability, autism, ADHD, epilepsy, retinal hematoma, cardiac rhabdomyoma, AMLs, skin features, chagrin patches, ungual fibromas, hypomelanotic macules, LAM, liver, and pancreas. So you can see the importance of surveillance because you never know when these manifestations will turn up. So it's important to continue having follow-up on a regular basis. So now looking at our clinic and what we provide for kids, because we're getting them at the beginning of life, we do genetic testing. So we're often getting infants who were just born because they were identified as having cardiac rhabdomyoma on fetal ultrasound. So they come our way. And of course, once upon a time, we weren't offering genetic testing to all, but we are now. And we're lucky to have, I forgot to put Stacy Houston down. She's our genetic counselor. And then, of course, we identify family members through this who have tuberous sclerosis. So sometimes we acquire more patients because siblings have TSC. And we also identify parents who never really followed up or have either been lost to follow-up, didn't follow their TSC, or didn't know they had TSC, and then we connect them with the Adult Tuberous Sclerosis Center. So that's something we do for all families as we're doing the family history, and we provide a referral to those to our adult center over at UHN. And then from a cardiac perspective, often these children have their cardiac rhabdomyomas now detected early. We have been asked to provide treatment for some cardiac rhabdomyomas with mTOR inhibitors, or everolimus or sirolimus. So they tend to kind of give that over to us to help guide that therapy. So we've sort of started doing that, but for the most part, most kids do not need that, and cardiology will usually follow children. And the cardiac rhabdomyomas, as we all know, they're the tumors that regress or become non-detectable in the first few years of life. There are the outliers that don't follow that pattern, and they're immediately followed by cardiology. And then follow-up depends on the extent of the rhabdomyoma. And over time, typically follow-up is usually every 1 to 3 years, and then some patients are discharged. And that kind of depends also on the cardiologist that you follow. But cardiology usually organizes follow-up tests, ECGs, echocardiograms, and Holters. We do an annual skin exam in our clinic. Dermatology used to come, but of course, when you're an infant, dermatology said we don't need to be here to see that because anybody can identify a lot of these manifestations. It's the things that we need to intervene is when we want to be referred. So we look very closely for the hypopigmented macules, shagreen patch, ash leaf spots, facial angiofibroma, fibrous plaques. So you can see all the different manifestations. And of course, if they have these, we send a referral to dermatology, where they will either begin like a topical treatment or laser therapy, depending on what the manifestation is. But we always do that because as we know, over time, you get new manifestations, including the hypopigmented macules that you can see. So it's important to do that. And even you think, don't look at the nail beds when kids are young. We've seen some things in babies. So important to do your surveillance. From a dental perspective, we inquire about dental pits, and we encourage families. We have a lot of families who come from low-income backgrounds, also new to Canada. So as part of our sort of surveillance for things like dental pits and growths in the mouth, we also encourage, and Samira is very instrumental in helping promote the Healthy Smiles program, which will cover dental coverage and treatments for kids up until I think around 17 years of age, so that they hopefully appreciate and have good dental health, so that they also have good cardiac health in addition. Ophthalmology, always we request for them to do a baseline eye examination to check for retinal hamartomas. We've had some kids who have had some eye or vision-threatening hamartomas. We've actually supervised sirolimus as a therapy for a couple of patients. And for those who are infants, and we start them on vigabatrin either as a prophylactic or preventative therapy, or for infantile spasms, if they're on therapy for more than 6 months or 1 year, we will have ophthalmology do an electro or ERG electroretinography to check for retinal toxicity. And it's kind of dose dependent. If they have a normal eye exam over time, or if they're off vigabatrin, we recommend just follow up with the community optometrist if there are any visual problems. Otherwise, ophthalmology will continue to follow them as required. And of course, a lot of people have brain manifestations, corticals, subcortical tubers, and subependymal nodules. And typically, you have your baseline study, and depending on the findings and the burden of disease in the brain, for younger children, we tend to, if they don't have significant burden, we will order an MRI maybe in 3 years' time so that we don't expose them to general anesthesia. And we also don't order contrast. We try and avoid ordering contrast unless we absolutely need to. So we try and prevent them from being exposed to gadolinium. And of course, if they have a subependymal giant cell astrocytoma that is showing progression, it's getting larger and growing, and particularly in the area of the foramen of Monroe, we monitor at least annually and a little bit more frequently neurosurgery. Sometimes if they consult on the children that have this, they may do a MRI brain every 6 months. Of course, when we receive infants
Maria,
who are, yes,
can I ask a question?
absolutely.
Why I don't know. I don't. I'm not in pediatrics at all. Is it specific to TSC that you're trying to minimize exposure to Gado, or is it just in general in kids that you're trying to avoid it?
Probably in general, not just in TSC.
Okay.
Unless they absolutely have to, so to minimize
I
that
agree
exposure.
with Maria. It's just in general, it's a lot of contrast for them otherwise, and they can see the lesions usually without, at least in the pediatric setting, we find. So yeah, we don't use it either, Maria.
Yeah.
It's interesting because it's true that in my experience too, the Gado, the contrast helps a bit, and so we always do it with Gado. It helps a bit in specific circumstances, but it's true that it's generally not essential.
No, and I think there was the TSC clinicians group that kind of asks questions back and forth. They were talking about using gadolinium, and they usually a lot do not use contrast with their MRIs, which was an interesting discussion.
Cool.
So yeah,
I learned something. Thank you.
there you go. Well, okay. And then when we have infants that are born, we try and get them in for a screening EEG. So if we know they have TSC, we try and get a screening EEG, even if they're asymptomatic, not showing any signs of having a seizure. And typically, the surveillance or the guidelines recommend doing it every 6 weeks up to the age of 12 months, and then every 3 months up to the age of 24 months. Sometimes that's contingent upon the availability of your EEG resources. And then if there are any abnormalities seen, children are started on preventative vigabatrin with the idea of reducing the risk of seizures, the risk of infantile spasms, and hopefully the onset of drug-resistant epilepsy. So you may have heard of a trial that was called the PREVENT trial, and that was for early treatment with vigabatrin. And they found finally in this trial that it does not decrease focal seizures or improve cognition in tuberous sclerosis. So what they did was they compared infants. They treated with anti-seizure medication vigabatrin at the initial detection of any kind of abnormalities, even if they weren't seizures. And the study wanted to provide as a form of early intervention. So hopefully it would improve developmental outcomes. And early treatment with vigabatrin delayed the onset and reduced the occurrence of infantile spasms in infants with TSC. And as we all know, that's usually first-line therapy in the treatment of tuberous sclerosis is vigabatrin. And the preventative effect was not observed for other types of seizures, so such as focal seizures, which are just localized, usually occurring on one part of the brain and affecting one part of the body, or for drug-resistant epilepsy. And there was also no measurable impact on the cognitive outcomes at the age of 2 years. And they also found that the EEG biomarker used in the PREVENT study was moderately effective in anticipating seizures. So some infants that had abnormal brain activity not on the egg, on EEG, did not experience any seizures, while others that had normal EEG had clinical seizures. And that kind of suggests to us that EEG can predict impending epilepsy in infants, but with TSC, not always correct. So the preventative effects of vigabatrin were limited to infantile spasms, and they didn't influence the onset of focal seizures. And the findings also indicated that delaying or preventing infantile spasms did not necessarily result in measurable improvements in the cognitive outcomes of children at the age of 2 years. But we still continue to do that. There's still controversy. How long do you keep them on vigabatrin? What's the dosing you keep them on? That question hasn't been answered. And we're certainly mining our data and looking at our children to see what effects we're seeing and what outcomes we're seeing. I like this graphic from one of the papers, which kind of shows you the occurrence of epilepsy. Epilepsy is sort of the bread and butter of neurology. And of course, anywhere from 80 to 90% of people with tuberous sclerosis will at some point have epilepsy. And this is a nice graphic to kind of show, when do subependymal giant cell astrocytomas occur across the age span, subependymal nodules that you have to monitor, tubers, and then you've got your epilepsy, so your infantile spasms. This indicates this is kind of the most common time point for it to appear, and then things kind of dissipate. Focal seizures tend to occur from birth and right on to kind of 10 years, a little bit longer, and then you can have Lennox-Gastaut, which is the really refractory epilepsies and the time points that they can occur. And of course, we treat, our infants, again, have their screening EEG. If they have active epilepsies, we'll follow them every 4 months. We provide telephone follow-up. A lot of times we will be the primary neurology group that follows seizures and treats, just because that's our area of expertise. And we'll do ongoing surveillance and treat with various forms. We use everolimus or sirolimus to treat seizures sometimes, CBD oil, all the anti-seizure medications, and even the surgical modalities, DBS, VNS, and of course, if they're a candidate for resective surgery, we'll certainly get them to the epilepsy monitoring unit and start their workup to see if they're going down the path of surgery, and we try and do that as early as possible on kids now. And then epilepsy surgery should be considered for medically refractory epilepsy and TSC patients. Especially special consideration should be given to children at the younger ages who have regression, and evaluation for surgery should be performed hopefully at an epilepsy center with people who have experience and expertise. Our renal surveillance is obviously done by our nephrology partners, and that nephrology kind of becomes the medical home, and Mark will talk about that a little bit later on, but we typically request an abdominal and pelvic ultrasound annually. So we want to see not just the kidneys, but we want to see what's happening to the liver and the other organs, because you can develop angiomyolipomas in the liver and cysts, and in other organs you can develop tumors in your pancreas. So these are things that we need to surveil, and our nephrology partners will do usually an MRI of the abdomen or just the kidneys to screen for angiomyolipomas, but we're actually finding things now. We never used to use MRIs, and now as we do that, we kind of find things. So, I think we're getting the full sort of spectrum of what TSC can do. Screening for hypertension is important. They do the renal blab work, and then treatment for renal AMLs, especially if they're 4 centimeters, with either everolimus or sirolimus. And when we first started in the TSC clinic, nephrology said we don't have capacity to treat the AMLs with the mTOR inhibitors. So neurology, we were initiating therapy, and we're actually doing the applications for government coverage for those who didn't have private insurance. So we had some good experience, but over time, nephrology has taken over, and we do partner because sometimes we're treating and having to titrate drugs that interact with the mTOR inhibitors, and we need to kind of be on top of ongoing surveillance to make sure that kids are safe with multiple therapies. So nephrology tends to kind of direct their surveillance because they're organizing tests to be done in lab work at the time when they have their visits. The other thing that we do religiously is screen for behavior and development. And we actually, Samira is excellent. She ensures that all our families receive the TAN checklist. And there are a lot of questions on that checklist. And as you know, we're looking at sort of the behavioral aspects of TAN and the psychiatric, intellectual, academic, psychosocial, and the neuropsychosocial level. And so we ask parents to send it in. Samira will review it. And if there are any issues, she will help to initiate referrals to various centers. For example, if a child looks like they may be developing autism, we'll send to a children's treatment program. So she's been a very instrumental person in helping us with that and making sure that our kids are referred in a timely manner. We also in our clinic do ask about behavior. So outside of the specific TAN questions, that's something that we're always discussing and wanting to learn more about. Now we do have a partnership with psychiatry, but there are long wait times. It's a limited resource. I think they're trying to build up our program. They have different service models. They usually direct neurology to treat and with antipsychotics. And if you're not familiar with those and the side effects, right now we're trying to partner with psychiatry to see if we can kind of form a model of care where we can have more of a collaborative approach in order to provide timely and consistent access and to see what resources are available, because you have to do a lot of times things like ECGs in order to check for arrhythmias. And it's been challenging for our families from the rural and northern areas. They have limited mental health resources in their community to help out with support services. However, we do have telepsychiatry work. They can access that, but again, sometimes it's only for more brief periods of time. So that's a work in progress. Here you see we have a little plan. So we have a electronic health record, and at the end of the note, we have this sort of, we go from a systems perspective. So if we have residents or fellows coming to us from pediatric clinics or genetics clinic, we have these guiding questions that help them to assess the patients, but also then to see what things they need for surveillance. And we then cut and paste this into the after visit summary so that families can know that this is when my last exam was, what I need to do next, so that they can kind of keep track of that. And then lastly, I'll talk a little bit about our transition program. We have many adolescent TS patients to transition, and really quickly we had a lot. And to date, we've had over 50 patients. So Samira helps to aid in initiating the transition process and guiding kids and families to apply for the disability pension, to learn how to access care and call for, prescription refills, all of that stuff for kids who are developmentally appropriate, and for those who don't, helping them to access the necessary services so that they have everything in place when they transition. So now we have some more structured resources. It still is a work in progress. We don't have anything sort of formally, but it's much better than it was. And we still have challenges with changing adult clinicians in the community. So there are more sort of adult partners, but that remains a bit of a challenge because sometimes they change. And again, you're sending new referrals and having to re-navigate. So we kind of tell our families, stay in touch with us even after you graduate. We want to know what's happening. We will always help you if you get stuck. And that is all I have. So I'm going to give it to Mark. I'm going to stop sharing.
There, now you can hear me. Great. Thank you, Maria.
Okay.
Anyone with any questions? See, usually there's a person who is moderating, but here I think we were asked to moderate ourselves. So anyone with any questions or comments? Is it what's the expression? The fox in the hen house, so we're running ourselves, but
Great presentation, Maria. Very comprehensive. I don't have any questions. Just I think you did an amazing job, and
Thank you.
It's a lot to coordinate and to organize. And I know how many patients are followed in Toronto, so
Yeah.
kudos to you. I guess like my only comment is with regards to renal MRIs. Are you guys alternating ultrasound and MRI, or what are you guys doing?
I don't
when
know.
it was there, it was a
Yeah.
lot of ultrasound being done and some difficulties with getting dual tests at the same time. So just curious what you
I
guys are
don't know
doing.
that there's like a set consistent pattern all the time,
Yeah.
because if there are fat poor lesions and they want to kind
Yeah.
of distinguish them a little bit more, they'll do that. But sometimes I
Yeah.
think ultrasound seems to be the more robust
Yeah.
test. And then they surprise me because there are AMLs that are so tiny. It's like, why are you doing an MRI? I don't get it.
Exactly.
Yeah,
Yeah.
and they're doing an MRI. So I think, I don't know if they're going to protocolize that a little bit more, because MRI, as we all know, is sort of a limited resource. You wait for a long time.
Yeah.
It's two different scanners, and even trying to coordinate brain MRI, and then they have to get off the scanner and get onto is a bit challenging. So I think that's something that warrants kind of a review of the surveillance that they do with the imaging,
Mhm.
just to kind of see, what is better, or do you need as much MRI? I'm not quite sure, Mark. I'm not sure if you have any thoughts on that.
we used to alternate between ultrasound and MRI just to save resources. But it's been a while now, but maybe 5 years that we stopped. So I only do MRIs. It's definitely a different situation. So it is, actually, I don't even know if I could. I could, but it would be very difficult to organize for sedation for a patient of mine. But fortunately, I almost never need it. So that's the first thing. And we certainly don't worry about GADO like the contrast as is done in kids. And in part, maybe also we're influenced by the fact, and I'll talk about that in a second, how AMLs are a major issue for us because they only get bigger with age. And so AMLs are the majority of my patients have AMLs. It's the majority of the reasons. It's almost always why I'm starting everolimus. It's almost the only patients I continue everolimus in is those with AMLs. It's the only reason to really. But so maybe that affects it too. But no, I'm just doing MRIs. And I mean, sometimes I have to do I'll do a CT abdomen, but instead of an ultrasound, but it depends. And then, because then you end up with issues of, is it something else? Do we have to organize for biopsy? If we can minimize biopsies, that's for sure. I'm motivated by that for sure.
Yeah.
So
it's a nice segue into your presentation.
Kidneys. So let me
neuronephrology, as we call it.
Let me share this. Now, if I do that and then I hit this, it looks like, no, you're not seeing the right one. I'm going to share again. I want you to see the slideshow. Here we are. And I'll make sure at the beginning, there. Share. Okay. So everyone can see my first slide well?
Yeah.
Great. So I'm just gonna, we have a good we have a half an hour. I'm in no big rush. I only have maybe I can't see the number anymore. I have maybe 12, 13 slides. So feel free to interrupt me if you have any questions. The way we tend to do things in adults is different for a number of reasons. Our general approach in adults tends to differ just because our patients are different in general, whether it's not outside of TSC, just people in general, they're different. And the considerations are different as people get older. And also, I'll talk a little bit about how in TSC in particular, the way the disease manifests itself actually changes with age. Yes. So I'm a neurologist. I'm an epilepsy specialist in Montreal, the head of the epilepsy group, our epilepsy group at the CHUM. So this is the University of Montreal Health Center. This is our hospital here. And I'm going to talk about routine follow-up in adults with TSC. It's not advancing. Let me click. There we go. So a little bit like Maria just did, I'm just going to sort of lay out the context of my experience and what we do at the CHUM. So our clinic was started in 2015. It was a collaboration between urology and neurology. So that's one thing you'll see is that who works in these clinics tends to vary a little bit between centers. So at our center, kidneys are a very big issue. And in fact, however, it is the urologist that helps us with those kidneys. The nephrologists tend to be far less involved. So it is Dr. Latouf who started the clinic with my colleague, Dr. Bérubé. It was in 2016 that I became the director, and I've been doing it since. When we first started the clinic, this photo here, I love this photo. I remember our old hospital fondly. I liked the old hospital, but what are you going to do? Notre Dame is where we were when I first started in the clinic. Our clinic was created in response to Philippe Major. So he runs the TSC clinic at Saint-Justine, which is the pediatric hospital in Montreal. He started in 2008, and it was that his patients were getting older, and he was asking his colleagues on the adult side, his counterparts, would we be interested in starting something up? And then Dr. Bérubé and Dr. Latouf were very enthusiastic about starting something. So our model is, I think, similar to a lot of models, the way we run the clinic. And certainly our model was influenced and inspired by Dr. Major, Philippe Major. So you see Philippe here, he's the one sitting in his very nice suit and looking very good there. In the bottom is a photo of Saint-Justine, so the new pavilion next to the old. So In our clinic, very similar to the way Philippe runs it, the neurologist is the primary, so the central pivotal physician for all people with TSC. So we follow everyone, whether they have a quote unquote neurological problem or not. So a lot of my patients, in fact, don't have epilepsy. They don't have an intellectual disability, about 30% of them, but we follow them anyways. It was decided that there should be one central group that followed everyone to ensure that there were no losses to follow up, to ensure that all the tests were done appropriately in a timely way. It is a neurologist that organizes for all screening exams. So I ask for certainly the brain MRIs, but I'm also the one who's asking for all the abdominal MRIs. I'm asking for the lung scans if necessary, and so forth. The other I certainly work with other colleagues and other specialties, but I involve them when when I deem it necessary. So because the kidney tumors are a certain size, and so I think maybe we're going to have to start everolimus soon, and so then I will consult Dr. Latouf so that he can give me his opinion on when we should do it, if we should wait, and so forth. And in the vast majority of cases, it is I who am starting the everolimus, and I'm the one who's following it and dosing it and looking for side effects. One exception is the pulmonary tumors. There it is my pulmonary colleague, Dr. Maganas, who tends to start the medication if necessary. It tends to be sirolimus, not everolimus. And so these are the way we run it. It can vary between centers, but the idea that I think it is very helpful, like at SickKids, like at the CHUM, like at St. Justine, to have that central team that's following everything. Here's just a photo of the team, and so the writing is too small, but I can tell you we do have a nephrologist, but again, not seeing all of our patients, urology, genetics. It is important to have colleagues because this is a very multi-systemic disease. But similar to SickKids, it is a virtual, what you can call a virtual multidisciplinary clinic. It is not a physical multidisciplinary clinic. That was tried initially we didn't even try doing 3 or 4 specialists at once. We just tried doing 2, having urology and neurology at the same time. And even that proved to be quite difficult. We did that I did it personally for about 12 months, and my colleague, Dr. Berivé, did it for about 6 months before me. And our rhythms are so different, right? How long I would spend with a patient versus urology, that it just became very inefficient. And then there was a lot of waiting on the part of the urologist, on the part of patients. And so we stopped that model. And now it's this virtual model where, yes, every patient always has appointments with me, with the TSC clinic. I'm the only one that does the only neurologist that does the clinic. But it is still multidisciplinary in the sense that we don't just refer to any urologist, refer to any respirologist, or just to any geneticist. We have very specific individuals in each group, so collaborators that are part of the clinic, that are recognized as parts of the clinic. And the reason for that was quite simple, that this is a rare disease. And the only way that anyone will develop any degree of expertise is that if you see enough. And so you can't have just any urologist seeing patients with TSC. It's best if it is always the same one, so that one urologist, Dr. Latouf, so that he's seen a lot. Because that's how you learn. That's how we as clinicians gain experience too in rare diseases, that we have to see enough patients, especially when it comes time to recognizing and making management decisions about more rare manifestations. And it's by having a larger clinic that it now has given us that sort of experience. So yes, a virtual multidisciplinary clinic, and we're fortunate that our epilepsy nurse also serves as the nurse clinician for the TSC clinic. One thing which maybe I'll mention here, that amongst these different specialists, I could tell you that the ones that are most often involved with our patients are urology, because the AMLs are dermatology for the angiofibromas and creams to help with that, or laser and so forth. And then genetics more and more, especially for genetics counseling, actually, for family planning is actually the most frequent reason now I'm referring patients to genetics, and not to make the diagnosis. The diagnosis is already made. I already know what's going on. It's more to help the patients if they're perhaps interested in having children, having a family. So we have a sheet that is similar to what they have at SickKids. This is ours. This is the one that it's in French, of course, but this is our summary sheet. That is, it's a way for me to quickly look at this and to have it's like a quick reminder of what are the major issues facing this person, the patient that I'm seeing. These are mostly things that are from the diagnostic criteria for TSC. And then when it comes time to talking about associated with that sheet, is a sheet that is like at SickKids, a reminder of which tests do we have to do, what are the results, when do we have to do the next test. Before talking about that and how we do it in adults, I think it's important, it's helpful to do a quick reminder that there are many different organs, many different systems in TSC that can be affected, but that it's not entirely random. In fact, it's not that. There is some randomness in it, but there's actually a lot of predictability too in terms of which organs are affected, but also when they're affected. So Maria alluded to this, how cardiac rhabdomyomas, for instance, that is a tumor that you see in neonates. That is a tumor that will sometimes, not infrequently be diagnosed prenatally or just antenatally, because there's a cardiac murmur or something. But that we know that with time, the vast majority of these tumors will spontaneously regress. So you may have to treat initially just because it's so large, but time is on your side, in fact. By the age of 2-3 years old, these are mostly resolved. I have a few exceptions, that patients that still have a small cardiac rhabdomyoma that persists, but that's relatively rare. I see Jennifer has raised a hand. Go ahead.
Yes, sorry. It's very hard to see the print on the screen.
Oh, because it is small.
But I'm trying to get a sense of actually with lamb, because I know that that's something that's normally not addressed until they're adults, but it's also something that's more prevalent in females.
Yes.
And quite frankly, like the age of 18 versus 19, depending on your province, is very arbitrary.
Yeah.
And age of adulthood for males is different from age of adulthood for females. So, I guess I see the green. Yeah. So like you have this gap of 14 to 18, a gap of 18 to 40. And I was sort of wondering if there was any statistics on the 16 to 18. Like, when is this stuff necessarily really starting?
So we don't have the best data. It's actually hard, and you can see that even reflected in this. So this is data from the Tosca database, this older database that was actually set up by a drug company, but was also used for other purposes. I have a certain point of view because I'm an adult physician, but you see all the the great details, the great efforts that go into all these very fine age groups before 18. And then all of a sudden, 20 years, decades are treated as all the same thing. So we don't always have the best data for people who, once they've hit 18 or so. I can tell you that in general, the literature suggests that you never see LAM before 18 years. And I can tell you in my experience that never happens either. It's always in older individuals, and it's, yes, almost always, not exclusively, but almost always in females too. There are some theories as to why that is the case, because it's their dependency on pre-existing AMLs, so the pre-existing kidney tumors, that the lung tumors are actually secondary to the kidneys. And that they're very sensitive to estrogen. And so it's as the estrogen levels increase as females grow older, that's when they form as well. But so no, it is definitely seen as an issue in adults. And yeah, it is fortunately far less frequent than other manifestations. They're not particularly common. It's about 10-15% of patients will develop Lyme, the lung tumors.
Again, though, I've understood that if you skew that to actually take into account the percentage of female patients that have it, it's much higher than that. So if you're looking at the overall,
sure. Yeah, if you're just looking at
it's my daughter I'm concerned about. So yeah.
No, sure, but again, yeah, even then, so it's maybe 1 in 5 or so. So I certainly have I probably have 20 odd patients with Lyme, and yeah, fortunately, trying to think. I've never had anyone with they generally do not affect pulmonary function very much. And now, of course, we treat with sirolimus mostly.
Okay, good. Thank you.
No problem. So cardiac rhabdomyoma is in the young, very young. I think going to advance. No, stop advancing. SIGAs as you grow older, so end of the teens, end of like 8, 9, 10 years old, early teens, you're going to develop new SIGA. So these are the brain tumors you have to worry about, you have to follow. So the brain MRIs are very important. But then, yes, all this is just to say, however, that the heart and the brain actually, they decrease with age, the heart especially, but even the brain, those tumors decrease with age. But what increases with age are the renal tumors and the lung tumors. The renal tumors, actually, and I can confirm this, that it affects the majority of adults. It's up to 80%. I believe in that number because that's what I see in my own clinic. And that influences the way we screen patients. So these are the screening recommendations. So this is the paper that published the most recent recommendations. This is the document that we use to follow what tests have been done and what were the results and what we have to plan, what we need to do next, similar to the one at SickKids. A few caveats, however, I would say, and because this document certainly, I would argue, had a certain pediatric point of view to it. And again, the literature is mostly focused on pediatrics, so it becomes more difficult to understand what to recommend in adults. But I can tell you that I'm not the only adult I'm not the only physician who follows adults who says that once you hit the age of 25, you do not need to do MRIs of the brain as frequently. So the general consensus is that we decrease this to about every 5 years, and sometimes even more, 6, 7 years, depending on whether there was anything previously that we had to worry about or not. We will certainly increase the interval between these MRIs of the brain. That we generally don't organize or worry too much about dentistry. A community dentist is more than capable of managing this, assuming that the patient is able to participate in a dental examination. And certainly, unless there is something that was already diagnosed, like a retinal phacoma, or unless there are new visual symptoms, we do not involve ophthalmology. I think 2 of my 130 patients are followed by ophthalmology. And I can say that 0 of my 130 patients are followed by neurosurgery for something in the brain, except unless it's for their epilepsy, but not for the tumors. No one's followed for the tumors. It's not. There's one exception. He's really an exception. Sorry. There's one exception, but that's very exceptional.
One of our neurosurgeons said, we're only technicians because you have mTOR inhibitors now. You don't need us.
No, yeah, you don't. Absolutely, which is great. What we do a lot of, however, are the MRIs of the abdomen and then scans of the chest. So looking for the pulmonary tumors. In women, we do that. All women get at least one scan at the beginning, and then we'll consider doing it every 5, 10 years, not very frequently. In men, I generally only do it if they have symptoms. If you have a cough, if you feel short of breath, I'll do a scan. Otherwise, I don't bother. And then one thing that we do is ECGs. So again, I do all the screening tests. So I don't send them to cardiology to have their ECGs done. I just order it myself. We do that every 5 years or so. The idea being that that cardiac tumor that they had when they were a kid may be gone, but that scar that it left behind could, in theory, create an arrhythmia later on. Actually, what data we have suggests that we don't really need to worry about this very much, that any arrhythmias induced by cardiac rhabdomyomas in the few studies we have actually resolve on their own too as the tumor resolves. But it's still recommended, and it's such a non-invasive test that I think I'm very comfortable ordering it. And of course, annual blood pressure measuring, that goes without saying. One thing about the dermatological exam, it's certainly, by the time you're an adult, it's about cosmetics. We're not worried about something suddenly happening or something turning into cancer. That doesn't happen. But we worry about the way people can worry about the way it looks. And then sometimes what can also happen is it can become painful, especially the periungual fibromas, the ones around the nails. Those can, they can catch on things, they can bleed, they can just be uncomfortable because of the size and on your toes. They're more common on the toes than the fingers. So we do ask our dermatologist, Dr. Marie, to help us with that. And sometimes if it's small and easily addressed on the fingers, she'll just burn it off herself. But sometimes she does have to refer patients to plastic surgery because they are the fingers. You have to be very careful about how bad scars on a finger can limit range of motion. You don't want that. So it takes plastic surgery actually. So, and again, actually, like I didn't mention that before, but like the kidneys and like the lungs, which increase with age, especially the kidneys, those tumors, the ones on the face, and as anyone with TSC knows, the ones on the face and the ones around the nails, they increase with age and time and sun exposure too. So, I've been taking longer than I expected. I thought I'd just have a few slides about issues that are perhaps a little bit more particular to adults. So we do see some more rare manifestations. I don't know if we know whether they're more common in adults or not. I sort of always assumed they were just because more time has passed. But, looking at the whole abdomen, not just the kidneys, I agree with Maria. It's important because these other things that we can sometimes see, they are rare, fewer than 1 or 2% of patients, but they happen. We have a few patients. Something that we have to worry about is long-term everolimus as well. Not what you do after 1 year or 2 years, but what do you do after 5 and 10 years of everolimus? And so I can tell you that if you're over 25 years old and your SIGA is stable, the brain tumor is stable, and the only reason you're on everolimus is because of that brain tumor, we decrease it, and we will even work to remove it altogether. Slowly over it'll take years of titrating down, repeating the MRIs, but we definitely do that. And actually, we're doing more and more with increasing experience. No one knows the right answer in the literature. You speak with John Bissler, no one knows exactly, but it is a general consensus that if it's a stable renal tumor that's been stable for many years, it is worth taking down the dose, follow what happens, because these medications have side effects. So we decrease the dose, we follow, and we even have patients who are now on alternating doses where they'll take it only every other day. Some people will just stop it altogether, and we keep following the kidneys and everything is going well. It depends. That's something that we're confronted with because we follow patients for 60 and 70 years at a time. And then just a final comment that a lot of our patients, I think, there's a certain bias, maybe less so now than there used to be, but there's a certain bias in that people with TSC who are diagnosed during childhood, they tend to be people with more severe manifestations. So I have a lot of patients with TSC that you could be considered quite mild. So a lot of patients that don't have intellectual disability and who are seizure-free don't have epilepsy at all. And so because of this, issues such as having children is a topic of important discussion for a lot of patients. So understanding the risks of transmitting it to your children, future children, the risks of the difficulties in predicting how severe the disease will be in your children, how it's not necessarily well correlated to how severe your disease is, issues of in vitro fertilization, of prenatal screening. These are things that we discuss with patients that we refer to genetic counseling for. Contraception in females. So we want to avoid estrogen. So exogenous estrogen is to be avoided in TSC. This is a general rule because it increases the risk of lung tumors and kidney tumors probably as well. We're not sure if progesterone-only methods are any safer. We're not sure. And that's why, like in epilepsy in general, actually, the intrauterine device is most often recommended, whether hormone-eluting or copper, one or the other. Most people prefer hormone-eluting. It's better tolerated, fewer side effects. And then to finish off in the same way that Maria did, the transition is very important. So we have a transition program for epilepsy in general that actually has a certain component that focuses on genetic causes of epilepsy, so including TSC, Dravet, and so forth. And so we have a transition program whose main goal, and actually Maria, you'll see the little tab in the corner up here. So there's an English translation of everything. And the idea of our website is to provide resources, like this is where you go to get this is where you go to get that. I'd be happy to share that with you once it's ready in English.
Oh, that'd be great.
It's about providing resources because there's so much out there. It's taking advantage of what's already out there. And that's it. This is just a photo of our epilepsy team in Montreal.
Very nice.
Maria, you have a question.
I do.